Hello, my name is Ruben Mesa, and I'm the director of the Mays Cancer Center at UT Health San Antonio, MD Anderson. And I'm joined today by my colleague and fellow hematologist, Dr. Robyn Scherber. Robyn, welcome.
It's great to be here this morning.
Well, we're here to provide the updates for the year 2020 regarding myeloproliferative neoplasms, new therapies, and new understandings of the disease. There are many exciting things that we're looking forward to this upcoming year. Robyn, what are some of the things that you're looking forward to about 2020 and MPNs?
Well, on a broad level, we have a lot of phase 2 data that's moving into phase 3, which means for MPN patients, more than ever, we're getting closer and closer to more therapies, more FDA drug approvals.
Well, an exciting time. So we're going to discuss each of the diseases in turn and heavily incorporate the important updates from the 2019 American Society of Hematology meeting. That meeting, held in December, brought together over 30,000 physicians, scientists, and nurses from across the world to Orlando, Florida, to discuss all of the updates in hematology. It really is the main meeting of all of the individuals involved with the science and therapy of MPNs into one place. So first, let's kick it off with essential thrombocythemia. Many exciting changes. We know our baseline therapies currently remain hydroxyurea and then anagrelide as second-line therapy. But there's been great interest in the potential role of long-acting interferons. And indeed, at this meeting, there were updates regarding the long-term outcomes of using pegylated interferon alpha-2A for patients with essential thrombocythemia. And those updates from the MPN Research Consortium show the safety and the effectiveness of using that therapy, particularly in the second-line setting for people that had previously failed hydroxyurea. That further validates the value potentially of that therapy for patients with ET. Additionally, we now have launching in 2020 the ropegylated interferon randomized phase 3 trial of ropegylated interferon, or P1101, versus anagrelide as second-line therapy for patients with ET that had failed hydroxyurea, but also have other difficulties associated with the disease. Other exciting things you're looking forward to in ET, Robyn? I know you have an upcoming trial.
Right. So here at the Mays Cancer Center, we are going to be looking at a new agent in essential thrombocythemia, which is an LSD1 inhibitor. And our hope is that not only will it help to bring down the platelets, that it might also help patients to feel better, and potentially for patients with a large spleen, shrink that spleen.
Excellent. Well, many exciting therapies to come for patients with ET. Next, let's pivot for polycythemia vera. We know that for polycythemia vera, we utilize phlebotomy and aspirin for all patients, and in many we use cytoreduction. Frontline as hydroxyurea, second line as ruxolitinib. But there are other agents clearly of interest. The first of them is there's interest in ropegylated interferon, in MDM2 inhibitors, and even in drugs working with hepcidin. Robyn, why don't you tell them a little bit about these updates?
Sure. So the first update is with that an agent called Pegasus, or ropeg interferon. And there were 2 trials that have gone on. One was the PROUD PV study, and then also the PROUD continuation study. In these, they were able to see this ropeg interferon initially versus hydroxyurea, and then also versus the best available therapy. What they were able to see long-term is that ropeg interferon, not only did it help with blood count control, but over time it actually had a higher rate of molecular response, where we were seeing the JAK2 in some patients go down, and they actually had some with complete responses, where they see that JAK2 go to a very low level that we can't detect it. Other things, we have the MDM2 inhibitors, and one of the ones furthest along is idesinutlen. There's also other agents that are being looked at. In this setting, we're able to see that, again, we see some blood count control and we see some spleen responses. That continues to go on in trials. For a little while, they were holding recruitment, but we're seeing that move forward. And then also we see these hepcidin mimetics. And essentially what that does is it inhibits the absorption of iron, but rather than feeling iron deplete or with low iron stores, you actually don't feel it as much. So what's exciting is the drug that's being moved forward was recently FDA approved in a non-cancer benign blood state. But here in PV, they're moving it forward to see if we couldn't potentially eliminate or reduce phlebotomies.
Well, this is very exciting. Certainly this offers many opportunities for new therapies in PV and really may give us many more options as we try to treat the disease. I frequently have found that phlebotomy and aspirin alone is likely inadequate therapy for many patients, but they've not been overly enamored of the current options that we've had. So more options, I think, will be beneficial in many levels. So finally, let's pivot toward myelofibrosis. It certainly is the most problematic of MPNs most of the time. And now for many years, we've had very favorable impact from ruxolitinib, the first approved therapy JAK inhibitor for myelofibrosis, improving splenomegaly, improving symptoms, and likely improving survival. But all of that said, there's clearly are opportunities to deepen the response, prolong the response, and there are individuals that either do not benefit from ruxolitinib or lose that benefit. So there clearly are an unmet need without question. In 2019, we had the approval of fedratinib. That JAK inhibitor as well is now approved for individuals with a platelet count above 50 that have myelofibrosis of intermediate or high risk. The American Society of Hematology meeting, we presented updates on the prior studies we had performed. One, we looked at a pooled analysis for patients with a platelet count between 50 to 100,000. Why that was relevant is that that's a group of patients that can receive ruxolitinib, but frequently do so at a modified dose. Receiving full dose fedratinib, it seemed from a pooled study from both the Jakarta 1 and the Jakarta 2 study that patients were able to receive the drug at full dose with both safety and efficacy. Second, we looked at updates regarding the second-line study, now utilizing more stringent criteria for defining ruxolitinib resistance and failure. In patients that met those criteria, we saw a solid 30% or higher response rate for splenomegaly or symptoms in patients that had failed ruxolitinib. So fedratinib is currently clearly an option for patients that have failed ruxolitinib, and certainly is a consideration in the frontline setting as well. Now, additionally, we have other JAK2 inhibitors that we heard further updates both at ASH, but new trials that are launching. The first is continuation of studies with pacritinib, a JAK2 and FLT3 inhibitor that continues to undergo studies now trying to particularly define its efficacy for individuals with a marked decrease in the platelet count to see the impact on improving spleen, symptoms, and safety. Finally, momelotinib, a JAK1 and JAK2 inhibitor, is being looked at for patients that have failed ruxolitinib with the hope that in comparison to danazol is superior for improving symptoms, anemia, as well as spleen and symptoms. So a lot of activity with the alternative JAK2 inhibitors. Fedratinib now approved, pacritinib and momelotinib potentially to become approved. But in addition, there were multiple new agents, both alone or in combination, which we heard further updates from ASH. Robyn, why don't you take us through some of these medicines?
Sure. One of the ones that is furthest along that we got updates on at ASH is a BET inhibitor. And this is a certain type of bromodomain inhibitor, which you don't have to know what that does, but essentially it goes in and hopefully alters the way that the cells mature and helps them to mature better. In this setting, they're looking at this BET inhibitor not only in those patients who've failed ruxolitinib, but also in patients who've had suboptimal response to ruxolitinib, and now in the upfront setting. So before people have used ruxolitinib. Early data has suggested that there's improvements in spleen, improvements in symptoms, and even some improvements in bone marrow fibrosis.
It's a very interesting drug, certainly in that this inhibition of bromodomain may have relevance for those individuals with the ASXL1 mutation. We know that's an acquired mutation for patients with myelofibrosis that sometimes can signal more challenging disease. Now, there were several other drugs as well, the Imago drug, luspatercept. Tell us a little bit about those.
Sure. So another drug is the Imago Biosciences drug, LSD1 inhibitor. And again, this is hopefully to help mature the cells that are not growing so well in the bone marrow. And again, in this setting, they were able to see symptom improvement, spleen size improvement, and again, some improvement in bone marrow fibrosis. So again, another exciting potential new drug. Luspatercept is a drug that is an erythroid maturation agent. And what that means is it helps the red blood cells to mature. With this, we can see improvements in anemia, and that were some updates that we saw at ASH this year, where we're seeing luspatercept in patients who have severe anemia or even transfusion-dependent anemia have improvement in their blood counts while receiving luspatercept.
Well, great. Well, that just even a partial list of all of the new agents being developed for myelofibrosis, really quite exciting. We have others that there are trials ongoing here at the Mays Cancer Center, as well as all of the MPN Research Consortium centers. Go to mpn-rc.com for all of those centers. But with a TGF-beta inhibitor, AVID 200, that we're excited about, as well as new trials which are upcoming. Now, the final thing, certainly Dr. Scherber and I have had a long commitment to focusing on better understanding the impact of having an MPN and also on symptoms and quality of life. But first, better understanding an MPN. Robyn, where do we stand with the MPN Research Foundation focused registry that patients can sign up for now, the MyMPN?
Well, exciting updates. The registry has now reached over 1,000 patients. And this year, more than ever, we've been working with the MPN Research Foundation in efforts to try to grow what we can understand about the MPN disease course, MPN symptoms, with the data from the registry. We're trying to collaborate closely with other physicians to really look at this data in more depth. And actually are asking physicians for their ideas on how to best understand and even utilize the data.
Well, great. In addition, we continue to be very interested in trying to find additional ways, in addition to medicines, to improve the quality of life for patients with MPNs. And with that, I would direct you to our MPN Quality of Life Study Group website, the mpnqol.com. We have many exciting things going on, including studies regarding yoga, meditation, and other cognitive therapies. Now, one other key thing as it relates to nutrition and the impact potentially of specific diets or nutrition to improve either the inflammation or symptoms in these diseases. Robyn, I know that's a particular area of your focus. You have some exciting things up and coming. What would you like to share?
Sure. So we've done a couple of different studies now looking at different types of nutrition, and we have been able to see that in from data that we have some mouse models that certain types of diets seem to improve the inflammation, and the same sort of inflammation that we see to be elevated in MPN patients. We're still working on getting things together to move forward a clinical trial here at the Mays Cancer Center, and work closely still with our good colleagues at UC Irvine to move the efforts forward there in their clinical trial of nutrition in MPN patients. One other thing I'd like to share is that one of the items that we presented at ASH was trying to put together a model of quality of life in MPN patients and better understanding how symptoms play in to impacting someone's quality of life, or essentially how well they live. And we were able to see that, again, symptoms play a key role, as well as depression and how patients are feeling in terms of anxiety. So this also helps to bring together our knowledge and understanding of MPN symptom burden and quality of life.
That was really very interesting work that with the analysis that you had done along with our team that really showed how key the symptoms are specifically as drivers of health-related quality of life for MPN patients. And in many ways, overcoming the impact of age or other illnesses or things of that nature. So really a very major impact. Well, a lot of exciting things going on. In parallel, the work that we've described, our basic science colleagues are working very carefully to best understand, why do people develop MPNs? Why do they progress? How do we better target them? We work together as a field, people better trying to understand the biology, people like us trying to develop new therapies, better understand symptoms, and clearly all of this work is very team-based. Team-based at our center, team-based with the MPN Research Consortium, partnerships with the MPN Research Foundation and many patient advocacy groups, and many colleagues around the country. So an exciting time, and we look forward to continued progress and improvements for MPNs. Any final words, Robyn?
No, just excited for all the new progress in 2020.